Chloride is the major anion in extracellular fluid and functions primarily with sodium and water to maintain a balance between intracellular and extracellular fluids. When sodium is retained, chloride is retained. Thus, decreases in sodium are accompanied by decreases in chloride. There is no recommended daily allowance for chloride, and most diets contain enough sodium chloride to meet the normal needs of the body. Chloride is absorbed continuously by the intestines along with sodium. The kidneys are the reabsorption and excretion of chloride, which are regulated by aldosterone and ADH. Within the body, chloride performs the functions listed on this slide. The normal serum chloride level is 95 to 108 milliequivalents per liter. Another thing to remember about chloride is wherever sodium goes, chloride follows. Hypochloremia or chloride deficient is a serum chloride level less than 95 milliequivalents per liter. A decrease in serum chloride is usually accompanied by a decreased serum sodium, potassium, or both. Hyperchloremia or chloride excess is a serum chloride level greater than 108 milliequivalents per liter. An increase in serum chloride is usually accompanied by an increase in serum sodium, potassium, or both. Changes in water and sodium balance affect chloride balance because sodium and chloride are attracted by a chemical bond and move through the body together. Chloride imbalance may also occur as a result of chloride loss or gain and abnormal retention or excretion, resulting in an actual increase or decrease in chloride. The shifting of chloride between intercellular fluid and extracellular fluid compartments, or water gain or loss, results in a relative decrease in chloride content. Excess chloride loss through vomiting results in the loss of hydrochloric acid from the stomach. Gastric suctioning decreases serum chloride by removing hydrochloric acid from the stomach. Diarrhea results in water, sodium, and chloride loss. Diaphoresis, or excessive sweating, may cause chloride loss because chloride is found in perspiration. Some medications act directly on the kidneys to increase urine production or decrease serum sodium levels, which then will decrease the concentration of chloride in the body. Inadequate chloride intake or absorption, such as excessive administration of 5% dextrose IV solution, can dilute the blood serum. Hyperchloremia may be caused by excess chloride intake, decreased excretion or retention of chloride by the kidneys, or chloride shifts between ICF and ECF compartments. Excess chloride intake can occur through oral or nasogastric tube or IV administration of sodium chloride. As stated previously, if a patient is hypernatremic, the patient most likely will also be hyperchloremic too. If the patient is unable to excrete or retain chloride, as with renal insufficiency and severe dehydration, their serum chloride levels will be elevated. The nurse should conduct a focused nursing assessment for chloride imbalance, beginning with a thorough nursing history. Interview the patient and family members to reveal any risk factors or pre-existing conditions that would contribute to sodium or chloride imbalances. Include a dietary history, inquiring about intake of dietary sodium chloride or table salt, and potassium-based salt substitutes. The nursing history should include lifestyle factors and current medication use. Measure and record the patient's vital signs. A thorough physical assessment is necessary because chloride imbalance affects many body systems. Assess each body system, observing for signs and symptoms of chloride imbalance as well as any associated electrolyte imbalances. Review the patient's laboratory data to assess for presence of hypo or hyperchloremia. Implement the healthcare provider orders to treat the underlying cause of the imbalance. These orders may include oral or IV fluid administration, oral or IV sodium administration, fluid restrictions, and medication administration. Teach the patient or caregiver the causes of chloride deficit. Instruct the patient that because most dietary chloride comes from table salt, he or she should increase the amount of salt used as ordered by the healthcare provider. Teach the patient to prevent chloride deficiency. Ensure that the patient or caregiver understands the specifics, rationale, potential side effects, and desired effects of the treatment regime. Include medication administration, nutrition, hydration, dietary restrictions, and foods high in chloride in patient teaching. If the patient is hyperchloremic, teach the causes of chloride excess. Provide specific information regarding the patient's medical diagnosis and related interventions and treatments. Teach the patient how to prevent chloride excess. Instruct the patient to avoid high chloride foods. Ensure that the patient or caregiver understands the specifics, rationale, potential side effects, and desired effects of the treatment. A listing of some foods that are high in chloride. Document all assessment findings and interventions per facility policy. Evaluate and document the patient's response to interventions and education. Serum chloride levels should return to normal reference range of 95 to 108 milliequivalents per liter. Other laboratory values should return to normal reference range. Vital signs should return to baseline. Underlying cause of chloride imbalance should be resolved. Level of consciousness should return to baseline.